Hoy arrancamos, digamos, durante todo el día tenemos un track importante de informática médica y de interoperabilidad con grandes invitados. En esta parte es mucha de invitados extranjeros. Así que la idea es, digamos, recorrer con los principales keynotes del mundo, les diría, un poco la informática médica y la visión de interoperabilidad. En este caso, digamos, si tenemos el lujo, ya un invitado de la casa, digamos, ha participado en muchas de nuestras jornadas. Siempre ha sido un placer recibirlo en Argentina. En este caso, bueno, las condiciones son distintas, pero es un gusto tenerlo a él nuevamente. Digamos, aquellos que no conocen a Ed Hammond, es básicamente el dueño de la informática, es un char emérito de HL7, y dio una visión de liderazgo y de una propiamente de visión de cómo es la informática médica en la mayoría de los aspectos de la informática en salud, ¿sí? Durante más de 50 años, digamos, es uno de los pioneros o de los principales creadores al inicio de lo que fue HL7, y estuvo involucrado en casi todas las organizaciones, digamos, en AMIA, en ACMI, en IMIA, en HL7 Internacional, digamos, ya como char emérito, en OPS, en el BID, trabajó en actividades del gobierno de Estados Unidos, y su trabajo más grande fue en la Universidad de Duke, ¿sí? Es donde está, digamos, todavía trabajando. Gran bailarín, great dancer, bueno, y es un lujo. Digamos, lo que nos viene a contar hoy en realidad no es algo que esté o que funcione, digamos, o que en una de esas se busque, sino que, digamos, gente se puso a ver, digamos, cómo todos los problemas que teníamos en cuanto a cómo funcionan los sistemas de información en salud, ¿sí? Cómo es el sistema de salud ideal, ¿sí? Entonces, digamos, muchos se pusieron a ver, bueno, qué es lo que debiera tener o qué es lo que pudiera tener cada uno de estos, y es la forma en cual vamos a tener su visión de buscar el sistema de salud perfecto. Thank you, Ed, to be here, and we are ready to listen to you. You can start your presentation.
Okay, thank you very much. You see my screen?
Yep.
Yes, okay.
You just need to maximize. You can start your presentation?
Yes. Okay. Can you see me okay? Can you hear me?
I think you need to put F5 or start your presentation.
Yes, I've started it. Can you see it?
But I see your PowerPoint. I would like to see the whole screen. Yes, perfect.
All right, now you're okay.
Okay, you're ready.
All right, first of all, well, a little start. Thank you very much for the invitation. And I would like to thank Fernando and HL7 Argentina, my friends at Hospital Italiano. My regret is that I'm not in Buenos Aires. It's one of my favorite cities, and certainly I've really been working on my Argentine tango so that I would fit within the dance part of that. But I really appreciate the opportunity of making this talk today. This is different than the talks that I normally make, and I think that probably you'll hear a great deal about fire in HL7, and my topic is a little bit different. What I really want to talk about is something that is become a passion with me, and I'm hoping that I can share that passion with you. I'm going to talk about a little bit about what the future should be, and I think everything that's happened is putting us there. So, you know, my first, I got to figure out how to. My slides are not moving. The truth is that the current healthcare system is broken, and part of that is simply the lack of communications between clinicians and patients. In spite of great attempts to have interoperability, we still don't have what I call total interoperability. We may be getting closer in some of the technical aspects and certainly the transport of data for interoperability, but we're a long way from getting the entire system of working together. Systems are siloed. We fix one thing, we focus on one group, one issue, or something else, but they're all a group of silos that really aren't connected together. But the field of informatics has gotten a little bit older now. I've been in the business now for a little between 50 and 60 years, depending on how you count. But one of the most popular commercial EHR systems was started in 1976. And what we've done is to evolve those systems, but we really have not brought them up to date and take advantage of everything that's happening today. And medical errors, at least in the United States, are the second leading cause of death. And I must admit that rapidly we're dropping to third place because COVID-19 in the US certainly has increased the risk of the leading cause of death in the United States itself. And part of the reason that we have all the problems, part of the reason that everything is broken is that there are some difficulties, some bumps in the road, I call them. The first thing is we assume that the barriers that currently exist are here to stay. And anything that we do new must fit within the constraints of those barriers. So every day when I'm talking about something new that I want to do, somebody says, you can't do that because. And I think that that's the problem that we're having is we don't focus on the constraints and try to solve some of those to build a system that we think is a system we really want to do. We spend much of our time and money doing workarounds rather than facing the true problem. And at one of the AMIA meetings in the US about 3 years ago, I looked at all of the presentations, and one of the things that I found is that 80% of the presentations were work around a problem rather than trying to solve the two problems. And then we're not really willing to tackle the hard problems. If it's too difficult to do, we look for some other solution, some other way around all of that. And we tackle today's problems with the tools of yesterday. So those are the kind of problems that we are dealing with. But there are some more bumps that we deal with as well. One of the things that we do, sorry, let me back, is we focus on a specific problem rather than looking at that problem in a total environment. In fact, if we looked at the total environment, the problem itself would disappear, and yet we spend our time in fixing that specific problem. We start with an assumed solution and attempt to solve the problem within the capabilities of whatever solution we have decided to use. We never look to see if somebody else has solved it and at least are currently addressing it. So we tackle everything on our own as a new problem. And strongly, I say, you cannot get the perfect system by fixing today's system. So some of the things that happens with today, physician and nurse burnout, certainly in the United States, are prevalent. We're having more and more people that are actually leaving the profession of healthcare because of the pressures and all of the things that they have to do that they don't feel have value to them. There's no equity in healthcare today. And again, I'm speaking largely from a U.S. perspective, but some of the recent events in the U.S. has really made us acutely aware of the lack of equity in healthcare in the U.S. today, and we're trying to look at focusing solutions to that problem. The most popular EHR systems are aged, as I've already indicated. A lot of new technology exists, but it's not being used in healthcare. Reimbursement in the US drives what data is collected, and I think that has influence throughout the world as to what data we collect and how it's coded. Claims database are used for observational research because the claims database perceptually are more complete than some of our clinical databases. So those are some of the problems that we really need to solve. So the focus of this talk really is on the perfect health system. And notice that I'm using the word health rather than health care. because I think the future demands that we focus on the health of the population, not on health care. Health care is important, but it's secondary, I think, to the health itself. Now, I would invite you to think as I make this presentation to you, how would you define the perfect health system? Are you capable of doing it? And it's not an easy task, because we keep thinking about problems of today's system and how to fix those problems, rather than thinking ahead of what, if we had a perfect system, what would that system be like? And how can we achieve it? Once we decide what the perfect system is, then how do we achieve the perfect system? And I'm not a perfect system because I left the P out of my slide. So I've created a project at Duke now that I'm calling the Galileo Project. And the reason I picked the name Galileo is because Galileo stepped beyond all current thought, all current conventions, all current requirements, all current laws. He opposed both the government and the religious organization to advance a brand new idea of what the universe was like. And instead of focusing on the earth as the center of the universe, he appropriately and scientifically said the sun is the center of our universe. And he proceeded to do all sorts of amazing things with this new definition. Ended up being put in jail, just to give you some idea of how tough it is to go against the system. So the goal of the Galileo Project is not to address perceived problems of today, but to step into the future. And I invited 24 clinicians in September to participate in a Thinking Aloud Zoom session. And I challenged this group to do the following. One, you cannot say you can't do that. Anything that is required for a perfect system, you need to state what it is, and our job is to make it happen. And you can't say that's impossible. Again, the same kind of challenges that you want to. So we wanted them to come up with a perfect system with no constraints. Now, this meeting was very productive, and I'm delighted that some of the thoughts coming out of this meeting are going to be included in some of the words that I'm saying. But the participants kept going back to today's problems, and I kept saying, if you solve today's problems, you haven't addressed the future, because by the time you solve today's problems, you're already out of date for the future itself. And so the first thing that we really talk about, the first step towards being perfect, is that without patients, we would not have a healthcare system. Without patients, we wouldn't need clinicians. And so, since patients are the most important part of our system, that I think that they should be the centerpiece of the perfect system. And we must approach everything that we do in health and healthcare with the perspective that we need to think about the patient, and is what we are doing something that benefits the patient. And if it's not, we need to rethink what we're doing. So we should, whatever we do, should provide the most value to the patient. So the theme of the perfect system is patient first. So there has to be equity in health and health care. There has to be access to care whenever and wherever it's needed. And certainly in the US, service rendered cannot be influenced by what the insurance would pay, but what's needed. So when you're going to prescribe a treatment or you're going to prescribe a drug, we need to have a system that lets us do the right and appropriate thing to do instead of worrying about whether the patient can pay for that. So the appropriate medicine or treatment must be available to every person. Health literally is essential. If the patient is to be first, they need to understand the significance of what they're doing and the significance of what somebody is doing for them as part of health and health care. And so we need to continue to teach health literacy. It needs to be taught in the schools, it needs to be taught to the population at large. The patient navigation of the system should be enabled. So how does the patient know where to go? How does the patient know the specialist to see? And so we need to have some ways of helping patients understand how they should engage into the system. And one of the things that the group of doctors that I brought together at Duke put forth the idea that that we bring clinicians to patients, not patient to clinician. Now that's important to note, because at Duke, if you've got 2 or 3 different problems, you may, on a single visit to Duke, visit multiple clinics. And Duke is not the easiest hospital to find your way around, and we find patients wandering in the hallways trying to find their next appointment. We need to change that and, again, focus on the patients. And there may be something like robotic help, robots that help patients find their way around the system. But we need a solution of having a better form of communication between the clinicians and the patients itself. Mental health has always been, I will call it, the stepchild of healthcare. It was something that we had a negative attitude toward. It was a personal stigma if you had mental health problems. But now we're understanding that mental health is extremely important, and certainly during this period of time with COVID. We're worrying about depression. We're worrying about autism. We're worrying about ADHD. We're worrying about PTSD. Mental health should come forth and be equal to the other kind of services that we're talking about. The biggest change that has been forced on us, and I think without COVID, we would probably be another 20 to 30 years before we would even consider virtual visits. But now virtual visits has been thrust on us. We're having to deal with the patient at a distance. And I think that that has been a great step forward in understanding what the future would look like. Instead of the overhead of brick and mortar kinds of buildings, we now are finding that Zoom linkages, the connection that we get with the patients virtually, this talk that I'm making virtually, although it would be much better being in Buenos Aires, I didn't spend the time flying down, all the cost of hotel and everything else and airfare. We're able to do this communicating directly. So virtual visits, I think, are going to be part of that perfect system for the future. And we're going to learn better how to do it. Even here in the US now, we are actually doing hospitalization in the home, and doctors are making virtual rounds, and in some cases, in-person rounds, but many virtual rounds to a patient that's being hospitalized. Obviously, that's a function of the nature of the disease that a person have, but a lot of things that we hospitalize can be handled directly in the home and probably in a much better environment for what we're talking about. So I think we'll see an increase of home hospitalization, and I think that's part of the perfect system itself. Another comment is, once a health system accepts a patient, it should accept full responsibility for that patient. There are cases that I know of at Duke in which Duke is unable to find out the diagnosis for the patient, the cause of what the patient's problems is. And so they just tell the patient, I'm sorry, we've done what we can do. We don't know how to do anything further. And then the patient is stuck with trying to look for other solutions. In the perfect system, once you accept the patient in a healthcare system, your responsibility is solving the problem. So if you need to go outside of Duke to another institution to find someone who knows the answer to this question, I think the perfect system, it's your responsibility to do so. There's a companion problem, and I would mention that Galileo purposely is focused to clinicians, but I think there are a number of other players as part of what's really got to happen to make the perfect system work. And one of these really is the patients. And so we've created a second project that's called the Archimedes Project. And what we're doing in this project is collecting comments from patients of bad things that have happened to them in the healthcare environment. And almost everybody, including actually some of the clinicians, because during our Galileo meeting, a number of the clinicians talked about some of the issues that they have of frustrations with the current healthcare system. And I think that what we really need to do is to get that information from the patients themselves, using natural language process and data analytics to classify these comments. And then part of the perfect system is being able to resolve these comments. Why are these negative experiences happen, and what can we do? And I think in this particular case, the reason I picked Archimedes as the name of this is the patients are the lever to push acceptance of the healthcare system. So why will this change be able to occur? And I think that's because the patients, better informed, are going to be able to demand it. But there are new forces now, and the patients are getting a lot smarter. And one of the things that I, as well as my friends do, whenever something is wrong with them, they Google it. It's opened up the knowledge and understanding of disease to non-professionals and changing the communication between a physician and a patient. I think in some cases, the patient may know more specifically about the disease they have than the doctor that's taking care of them, even though that doctor has multiple diseases to worry about, keeping up to date and all those kind of challenges, but the patient has a vested interest in themselves. And so I think we're shifting care to outside settings. We're collecting data, analyzing that data in real time, and we're much more responsive to what the data is really telling us. Now, the patient-reported outcomes is a part of the perfect system for the future. And what we need to do is for those patients-reported outcome, we need in the perfect system to integrate that data into the electronic health record and share that data with the clinicians taking care of the patient. So we're seeing that kind of change to occur. Patient communication. This is a challenge, but I now have come to the conclusion in all the things that we are being forced to do now in both education and in healthcare in the United States, and I think in most countries, every patient should have access to the internet. Patient right means that there's so much now that's digital. It's the right of the patient to have access to that internet. And one of the things that we need to do is to make sure that we have total coverage of the country. Every patient should have a device capable of digital communication and interaction. It's a cheap treatment, and doctors should be able to prescribe it if the patient doesn't have it, or the system should be aware of that and make effort. And it may be a smartphone, it may be an iPad, it may be a computer. And with a lot of the education now, as part of COVID being virtual, we're trying to begin to address some of those problems. But I think in the case of the United States, Medicare and Medicaid should provide access to the internet, hotspots that people can access, and a device with which to use this. Patients should have access to all their healthcare data. That's required in the United States now. And increasingly, patients are beginning to pay attention and looking at their data. So when I have an encounter at Duke, my data from my lab results and from my clinician interaction, I'm able to see that probably within the same day. As soon as that data is available to me. And I can see the remarks the doctor is making as well as looking at the lab data. I'm much better educated in making decisions about my own health as a consequence of that. So now taking a step beyond patients, the second area that the clinicians focused on was community. The community must engage in the health system. The community must accept equal responsibility for the patient within the health system. That responsibility includes issues of transportation. If the patient doesn't have transportation to get to the healthcare facility, then they don't have access to healthcare. They need access to healthy food. They need access to social events that deals with mental health, depression, and things of that nature, entertainment, sports, what have you. They need access to parks for exercise and provide patient safety and health and education. And the community needs to understand that there's a fiscal responsibility as well as a social and ethical responsibility for making all of this happen itself. But those are the front end of this. But the big changes that have to occur for the perfect system is the clinical environment itself. So remarks now are going to focus on that particular part of it. The first thing is that we are in a system now of where there is a tsunami of data. So there's scientific data coming in as new research is being done in new areas of all of that. There's new sources of data from video, media, blogs, medical devices, and so forth. There are a lot of sensors now coming in with data, both of the environment itself and social. And with COVID, this is very important because we need to know exposures. We need to be able to track individuals to control the spread of the disease itself, and then healthcare itself. So we have to worry about sharing this data, making the data flow equally anywhere. Data sharing and data standards are part of what has to happen. But these are a couple of my favorite slides. We've used, the standards community has used the Tower of Babel for many, many years. I can't remember the first time I used this slide, but it's got to be close to 40 years ago, I think. And talking about we don't speak the same language. But I want to read this quote from Genesis, the Bible, 11. And the Lord came down to see the city of the tower the people were building. The Lord said, if as one people speaking the same language, they have begun to do this, then nothing they plan to do would be impossible for them. Come, let us go down and confuse their language so they do not understand each other. Today's version of this, as I call the Tower of Interoperability, and the health professional said, let everybody choose their own data elements and their own terminologies, and we can map it all together. And the result was interoperability breaking chaos. And one of the things that I think that will keep us from having that perfect system that has to change is we have to go to a common data model. Now, the problem is, given this picture, what standards do we use for the common data model? There are so many choices, and we're making different choices. And how do we bring this community together? It's mandatory that we solve this problem for the perfect health and perfect health system. We have to be able to exchange data, not only within our own local areas, our local regions, but we also need to do it from country to country. And I think COVID is an example of the mobility of people, the spread of this disease rapidly worldwide of COVID-19, that it became a pandemic is a consequence of people moving from country to country. And that spread of that disease really forces us to look beyond country boundaries and look at common ways of sharing data across that. So collapsing this page into a single solution, it may involve the same people, but they're working together. They're not creating two systems and mapping from one to the other. They're creating a single system by working together. So we need to remove the competition among these sources into collaboration and oneness among the sources that we're talking about. So a third project that I've been trying to get off the ground, I asked myself the question, if we knew everything about a patient, could we do a more optimal job of guiding an individual to a high quality and the longest possible length of life? That's the basis of the Human Metric Project. And I'm using the word guiding rather than making sure they have a higher quality life, because it ultimately goes back to the individual. We can tell the individual what they should be doing, but we need to do things that will make the behavior change occur that would appreciate that. But the project of the Human Metric is more than that. It identifies the types of data we must collect, and critical behavior, social determinants of health, economic, geospatial, genomic, and environment. And it first addresses the common and consistent data elements, including a common language. It addresses how data is collected. It addresses how the data is to be used, and it addresses packaging of the data. Now, this is probably a challenge to some of the terminology vocabulary vendors, and we don't want to throw away the intellectual content and all that. What we need to do is to build it into a model in which the data elements itself contains the requirements to do what we need to do. starts with a data element. And these data elements need to be atomic level terms. So we don't want compounded terms as the beginning of this. We want to build from fundamentals because a perfect system needs that level of specificity to be able to do the analytics that we have to do. Then from that, we build data models that are complex structures from the data elements, such as data pressure, blood pressure, or heart murmurs. And then from that, we create data sets. Now, part of the current problem is we confuse data elements, data models, and data sets. And what we need to do is to understand what those definitions are. Data sets are a grouping of data elements that define things that we want to do. We define phenotypes with data elements. We define risk models with data elements. We define knowledge models with data elements. We define registries with data elements. We define care plans with data elements, and so forth and so on. So I think you get the idea of what we're really talking about. So what's a perfect health system for clinicians? Well, and this is coming from the clinicians that participated in Galileo. First of all, they wanted access to any and all data about a patient. Now, in the US particularly, that may be a challenge. We have a mobile population, and even if you are going to 2 different hospitals simultaneously, at Duke, we have a number of patients that are seen at Duke and seen at UNC, healthcare system, and multiple clinics. And we need to have some way of bringing that data together. They also are interested in longitudinal presentation of patient data aggregated across sources. Now, one of the things that clinicians saying in the perfect system, I will be able to go back to the beginning of a disease. I will understand what the patient was like before the disease started. How did it start? How did it get discovered? And how does it migrate to the present point? And looking at all of the major events affecting that disease that's happened over that course, what the treatments have been and everything else. Most of our EHR systems are not structured to be able to do the creation of that longitudinal presentation, that time-oriented presentation of data. The perfect system demands that we're able to do that. We need high quality and trustable data available when and where needed. And that's still a problem because we are getting conflicting information out of the same EHR. And if you can't believe the data that you're getting, then what you do is to recreate that data or look for answers yourself itself. Presentation of the data as the clinician wants to see it. The problem with the commercial EHR systems is that one size fits all. They present the data independent of the specialty of the clinician that's looking at the data. And it takes time to sort through all of that in the mind of the human, the clinician, and we need to solve that problem. The perfect system is able to do the presentations in such a way that it's clearly understood. We all speak the same language, a seamless world of data. We need new forms of data capture. If we can capture the data automatically, we ought to do so. And we need to use artificial intelligence to reduce finding the right data from big data. So I've already mentioned this, and I'll just quickly show you this slide. But here are some of the things that are great popularity in the US now. These are called social determinants of health. And it's interesting to know that 40% of the data that impacts the quality and length of life of an individual results from behavior. And so we should be focused on changing that behavior. Genetics is 30%. Social economic is 15%. The environment is 5%. And clinical is only 10%. So I spent most of my career focusing on clinical data, but it's only 10% of the data that impacts the quality of life and the length of life of an individual itself. Mobile phones have really changed the world, and I've talked about that already. Wearable sensors. So if you look at my EHR at Duke, the only data in my EHR is when I go in for my annual physical or a couple of times that I've been hospitalized. It's the data while I'm sick. But if anything is going to happen to me, the first clues that something is going to be on my body. And if I've got sensors that can pick that up and direct me or engage the right people to intervene at the appropriate time, we're going to see a much better outcome. And I think that's what the perfect health system is going to do. We could use smartphone apps for data collection, text, check boxes, photographs. The resolution now is so very good, we can make clinical diagnosis, particularly in fields like dermatology. Smartphones can be used for education, behavior modifications, very important, and more. So there's a huge number of wearable sensors that I think we're going to see greater and greater use, more and more data, and that's really going to require us to do some additional analytics to accommodate understanding that data. Data sharing becomes the norm. I think we are going in the future, what we're trying to find about COVID, we need to have data aggregated across multiple settings to get enough data to really increase the knowledge about this disease and its course of the disease itself. Success of that is going to depend on interoperability. That requires standards, and use of FHIR has increased significantly as a result of that. So I think the new EHR is going to support multiple uses of data rather than secondary. We think about data focusing on the clinical collection of data, and yet there are so many other uses, including research, that means that we need to think about this. I'm collecting data for all the uses. The data should be stored in what I'm calling a data box. And this is not just the EHR. At Duke, there are multiple databases about patients. There are data collected here and here and here and here that aren't part of the EHR. The clinician needs to know these, knows how to access them different ways in many cases. That all needs to be brought together, put into a single box. And that data box just simply performs REST services. You can create, read, update, and delete. Data storage is independent of data use, and user functionality is performed independently by functional apps. So you can do the specialization, you can add new technology, we can address new requirements, and it enable a competitive market now. Suddenly, we're back to moving to where the competition will drive some of the practices down. And clearly, query-based interactions, pull over push. If I've got a question, I want the answer to my question. If you dump a lot of data on me, you're not making life any better for me. So big data has a huge impact. And I don't know where we are now. In 2017, we had 44 zettabytes of new data in the US daily. I'm sure it's probably maybe gone up a couple of orders of magnitude for that. Computable knowledge is an award for big data. So we need to build these databases, and COVID-19 certainly is telling us. And we're seeing different types of databases that need to be accommodated in the data box, but the clinician shouldn't have to worry about what we really are talking about. So this is sort of an overview. My friend Bill Stead from Vanderbilt said, humans make decisions on 5 to 7 points. But with all the things that I've talked about, we literally have thousands and thousands of points. So do you want to trust a human making a decision on 5 points, or do you want to trust a smart computer making decisions on thousands and thousands of data points that we're talking about? So I think we're going to see this change in which I think most analytics and decisions will be made by computers and executed directly. There's no point in telling the computer, telling the doctor, you need to order this lab. Just order the lab, because the computer has access to more data and analytics of that data than a human does. And so make that happen. And the role, the physician is going to change. I'm not proposing the elimination of the human, of the clinician. What I'm saying is the computer and the human are much smarter than the human by themselves. And in fact, I could say also the computer and the human are much smarter than the computer by itself. The one thing that we haven't learned how to do in artificial intelligence is to handle unforeseen circumstances. Humans can deal with unforeseen circumstances. We've got lots of evidence that computers are not capable of doing that. So that's the problem that we actually are dealing with. So perfect requires these list of things that I've already talked about. I won't go over this again, but a perfect system, this is what we really have got to be able to address from there. And there are changes that have got to take place. We need the integration of images and enhanced use. Images has always been another stepchild of the healthcare system. We need to integrate those, make them available, show out the highlights of what the clinicians need to know. We need to learn how to incorporate biomarkers and genomics into the care of patients. We need enhanced registries, automated population of the registry, research, automated clinical trials, observational clinical trials, pragmatic clinical trials. We need partner apps to tell the complete story. Not only do I want an app to measure your blood pressure, but I want an app to tell me what you were doing before I measured the blood pressure itself. Perfect provides the right data for the right patient, for the right clinician at the right time for the right person. So just getting the closing up of this pretty quickly. We're talking now about a new area, the second machine age, that really builds artificial intelligence. It has many names in different levels, but machine learning, deep learning, artificial intelligence. Medicine has been picked as probably the area that will most benefit from artificial intelligence. We can teach computers to do specific things. We're a long way from artificial general intelligence. That's my comments, that they cannot deal with unforeseen. Computers learn from the environment. We need sensors to read the environment. What we gain through AI is specific narrow tasks, which includes decision-making, surgery, and tasks. The problem is people are afraid of artificial intelligence. It's the John Henry syndrome. John Henry was a steel driving man, and he could outdrive steel, making railroad tracks and that sort of thing faster than any other human. But technology came in and created a machine to do it and put John Henry out of business. So that's a part of the song. So the things that we're talking about, and I'm not going to spend time on this slide, is artificial intelligence, machine learning, deep learning, and they all fit within the same kind of time frame that we're talking about. It's a new field called data science. And the perfect system is going to have an embrace with data science, but it's got to also embrace implementation science and operational science. We've got to take what we're learning from data science and apply it in such a way to support the concept of a perfect system. Now, narrow AIs versus general AIs, as I've already talked about a great deal, this is a robot that was developed by David Henson out of Hong Kong. And it's very impressive what this individual can do, but it's a long way from where the current state of the art is in doing all of that. But AI, for example, can deal with such issues as this. Psychiatry shortage escalates as mental health needs grow. We don't have enough psychiatrists. And there are roles that robots and AI can play that will help solve the shortage of clinicians in this particular area. So just some quick slides here. Is CMS had $1 million prize for an AI Health Outcomes Challenge. AMA voted to promote augmented education for clinicians and house staff. Former CEO of IBM says by 2021, cognitive AI will impact every decision made. Now, COVID probably set that back a little bit, but we're getting closer and closer to making that true. So I don't think it's going to be far off. Just a couple of headlines of people using AI to boost clinical documentation. Artificial intelligence could find a future coronavirus. So I think we're seeing more and more things. Soon, it will be hard to imagine a doctor's visit or a hospital stay that doesn't incorporate AI in numerous ways. With healthy clinical evidence, we can see AI become a mainstream in clinical settings, providing a positive feedback loop of more evidence-based research and use in the field. In addition, AI and ambient sensing technology will help rehumanize, going the other direction now, by allowing doctors to focus less on patient work and administrative function and more on patient care, guided by the intelligence provided by artificial intelligence. So I'm running out of time, so I'm not going to give you, I'm not going to read these to you. They're in the slides that you can see. But much of what we're doing now, patient education, acquisition of patient, intake and scheduling, a lot of the administrative functions that we currently are doing we can do with artificial intelligence. Something such as being able to schedule appointments as they are needed, same day appointments, 1 week appointments, and then other appointments that can become. We can worry about missed appointments. How do we accommodate missed appointments? So AI can look at all the factors that relate to the odds of having a patient show up, and then provide the incentives to that patient to show up, the reminders. And much of that we're beginning to do today in the US itself. Images, we need to recognize the border of an organ to suggest where to cut off a skin. Three-dimensional models prior to surgery. There are a number of examples now of where the use of AI and images is having a significant impact on much better uses of imaging. I like this last quote: thinking in the way humans do, reasoning from a few observations to suggest a novel scientific framework, as Einstein did with the theory of relativity. Can't get there yet, but that's the way that we're coming down. We're seeing some ways of really doing that. Some projects that are happening at Duke now, we're dealing with autism. We got patterns and recognition and electronic health records, management of opioids, medication management, ophthalmology, certainly in virtual and distance radiology, exercise physiology, Forge, which is a data science effort at Duke itself, and the Duke Institute for Health Innovation with the implementation aspects of what we were talking about. AI models, again, we can do tremendous number of things. We can identify patients, for example, with a high risk of progression of kidney disease, high risk of complication of diabetes, high risk of complications after surgery. We can worry about readmissions, predict it's going to happen, and prevent it from happening. AI, the access to data, creation of knowledge, understanding outcomes, all of that is going to make life a lot better. We're going to see an increased use of robots. And lastly, virtual, mixed, and augmented reality is going to be a part of the future itself, both for education, both for teaching clinicians how to do certain kinds of things. We can offer, and augmented reality already is used a great deal, for example, in the military, and in first, they're using virtual reality to create real-looking events with real-world experience of dealing with those. And I think we're going to see a lot more of that in the future itself. So perfect in the future. Society should demand the perfect system. Can we make the changes necessary to enable the perfect system? At Duke, we're now having discussions with leadership. And it's interesting because they agree with some of the suggestions we're making. What they don't understand is how to change the current system to get there, because it does demand change. And how much will the transition cost? We currently look at the cost of a single event. And in the new system, in the perfect system, we need to look at the cost of the total system, because healthy people save money, but they don't directly save money to a healthcare system whose bottom line depends on money paid to them. And if we have a healthy population, they wouldn't pay any money to them. And so that's the constraint. Should it be global? Have I gotten your interest in the perfect system? Can you use the word perfect? I think it has to be global, and some of the culture is different, and some of the things that we do may be different, but the philosophy, and I'm hoping that's what you will pick up from this talk, will understand that what we really want to do is to quit trying to fix. Don't patch the shoes, get a new pair. Or maybe we find something even better than shoes. So who will be the leader? And my challenge to you, the people at Hospital Italiano, the people at HL7 Argentina, the leaders of health in your countries, I challenge you to be the leaders to make the change to the perfect system. So thank you very much.
Thank you. Thank you. Great presentation. We have a couple of questions in the chat, so I will read. The first one is from Fernando. Do you think such healthcare system could be possible?
Yes, I think it would be possible but it may take forever. I mean, you know, the first time I actually dealt with this topic was 1965, and I had all of this coming to happen pretty much on automation and the use of artificial intelligence by the year 2000, such a magic year. It didn't happen then, but I still think that it's going to happen. The perfect system is probably going to happen in the far distant future, but by knowing that as the goal and taking steps in that direction immediately will begin to start us on that journey. We will profit from minor kind of changes that we're doing. COVID-19 has really helped us make those steps by being forced upon us. And I think life is a little bit easier. Clinicians are talking to me that would have never talked to me before COVID-19 because they were stuck with what they're doing, believed in what they're doing, and wouldn't change. Now I find a much more receptive audience from the clinical people. I think the technical people, what we've done over the years is maybe watch what clinicians were doing and trying to automate that, trying to make it better. Instead of recognizing what they were doing is what they were doing because it's what they were taught to do, what they had the tools and the methods of doing. So rather than trying to duplicate a patient record, for example, which is where I started out, what I really need to do is to address what do they really need and want and design a system to accommodate that. So the question is, you know, will we get to perfection? Probably not in any of our lifetimes, but we can certainly move from where we are. We can start the journey in a pathway to that perfection. And that's what I'm hoping to achieve with this.
Right. And we have another question from Esteban. What are your thoughts on collaboration versus competitions in terms of interoperability and the fragmentation of the knowledge and systems?
Competition, unfortunately, is what is our human nature. When we play soccer, football, sports, and everything that has a winner and a loser. And our society is geared in such a way that I can tell you who won many championships, but I can't tell you who lost those same championships. I can tell you when Duke won national titles. I can't remember everybody we beat to get the national title. So we've got to overcome that natural instinct. And it depends on what you mean by the word collaboration as well. I've started using the word independently merger. And by that, it means that we do things retaining our own identity, but we create a single product, and creating two ways of doing things and harmonize by mapping one way to the other is not part of the perfect system. It costs money. It's never up to date. It's fraught with errors. What we really have to learn how to do is share responsibility and share credit. I mean, the old statement from Harry Truman, if we don't worry about who gets the credit for anything, we can do much more. And I think that's the kind of thing that we have to talk about. And that one slide that I showed, this whole number of people, if we can learn how to work together, take the expertise of one group. And I will tell you that HL7 has just in the process of negotiating a statement of understanding with OMOP and Odyssey that creates a common data model. And we're looking at ways of taking the intellectual content of OMOP and building that into the intellectual content of FHIR. If the electronic health record is built around the resources and the attributes within the resources, the data elements within the resources that are the same resources that are in OMOP and other common data models, then we have interoperability from the perspective of the data, and data drives everything. And so I'm using the word collaboration, but it really is more than that. What we really have to do is to become twins. We have to be joined twins. in which we are creating a product together, each of us getting credit and each of us accepting responsibility of compromise if necessary. And I don't even want to use the word compromise. What I want to use the word is we reach a conclusion, this is the right way of doing it. And so, you know, I make the joking statement to my students that anybody that agrees with me doesn't add anything to my success. It's the people that disagree with me that helps me rethink what I'm doing, sometimes make some changes that are better, but sometimes strengthening the reasons for doing things. And I think that's how we really have to do. We have to get it, the collaboration in groups is the ability of arguing about a solution in such a way that we ultimately can get what is the best possible solution that both groups agree to. So I think that's the way we really need to move, rather than each of us doing it our own selves and then mapping.
Okay. And the last question, how do we align incentives between payers for this to happen? Speaking about interoperability and healthcare system as a whole.
That's the toughest question that you could give me. It's
Biona was.
yeah, you know, I don't know the answer to your question, but for me, what we need to do is to step back and look at reimbursement at a much higher level. If it's fee for service, then I'm not going to be able to reduce the cost. If the amount of money a clinician makes is a function of how much money he charges the patient, then that physician is going to charge is going to do as much as he can to get as much money as he can. So it has to go back and look at the larger system. And maybe this takes groups like government, maybe it takes groups like healthcare consortiums. We've got to look at the price tag at a higher level than we look at the price tag now. And I think importantly is the reimbursement record should not be the best data that you can find over the clinical record. I don't think there should be a reimbursement record. I think what we should do is to look what's done clinically, and the cost of that, however it is reimbursed, ought to be how we measure performance. But, you know, for me, I'm not interested in the lowest cost system taking care for me. I'm looking at the best cost system taking care for me. So I want the money spent that gives me the highest quality and the longest length of life that's possible. How can we get society to do that? Tough question. And again, I think it's something that we need to understand and begin to talk about, that reimbursement should be secondary to healthcare, and you don't even need a record to do it. You do it from clinical data.
Great. Well, that we are run out of time, but thank you very much, Ed, for your presentation, your presence, and all your knowledge, and for sharing with us in this occasion.
Thank you very much, and I hope that was a talk that fit the mode of this meeting. I'm impressed by the number of people you have registered for this meeting, and I wish you the best.